This is a fascinating story of vascular access creation and its management over 8 years of follow-up. I hope you enjoy this presentation. We start with our patient at 2015. He was a 60-year-old male with diabetes mellitus, ischemic heart disease, severe cardiovascular atherosclerosis, and state post-percutaneous coronary intervention (PCI). 1 month later, we had a coronary artery bypass graft, and then he started hemodialysis via right permacut. He also had hypertension, hyperlipidemia, and the left ventricular ejection fraction is 50%. The patient came to me for vascular access evaluation and creation at 2015. He already had a perm cut, and we did a color duplex examination for access mapping and planning. On the left arm, you can see that the cephalic vein in the forearm is 3.5 mm in diameter, and the basilic vein is 6.8 mm in diameter. The arteries are not calcified, and you can appreciate the normal flow. There is brachial artery high takeoff in the axilla. On the right arm, the cephalic vein is borderline, and the ulnar artery is occluded. Thus, the only option is basilic vein transposition. Many centers use AV graft fistula, but our results are better than graft, and we use them only when there is no other option. In the left arm, there is also high brachial artery takeoff. In conclusion, the options are radial cephalic fistula on the left, and on the right, basilic vein transposition. The patient was scheduled for vascular access creation, but unfortunately, he had exacerbation of limb ischemia with non-healing wound infection and long hospitalization. On angiography in 2015, the SFA with severe stenosis and occlusion at the adductor canal. The popliteal, tibial, and peroneal arteries also occluded. The patient treated by femoral artery PTA with stent graft and then peripheral angioplasty. While in hospital at other center, bilateral venography was done. The quality is poor, and the flow in the brachiocephalic vein is not clear. On the left arm, the cephalic vein in the upper arm is draining via small collaterals, and the main drainage is via the basilic vein. On the right arm, the quality is poor, and it is not clear if the brachiocephalic vein is occluded by the perm cut. We decided to do radial cephalic AV fistula on the left arm. In July 2015, after prolonged hospitalization, the angioplasty failed, and the right below the knee amputation took place. Let me remind you the surgical plan. In this case, radial cephalic AV fistula is the best approach. In October 2015, a left radial cephalic arteriovenous fistula took place. The steps of achieving zero failure are detailed on these slides. Ambulatory service, sedation, regional anesthesia, tourniquet after blood, exsanguination, microsurgery technique, no-touch technique, and eternal post-operative surveillance and maintenance. 1 week post-access creation, sutures removal and evaluation took place, and we enhanced the fistula maturation process. 6 weeks post-operative, the vein diameter was 5.3 mm, and the access flow was 650 ml per minute. Thus, we initiated cannulation. 4 months post-op, the patient is doing well. The cannulation size are around 8 mm, and the flow risen to 1 liter per minute. 8 months post-operative in July 2016, you can notice the brachial artery high takeoff in the axilla. 20 months post-op in June, the patient developed Still syndrome, particularly in finger 3, 4, and 5. He had high excess flow, more than 1500 ml per minute, with pain when the dialysis machine reached 250 ml per minute flow. This is the duplex mapping. Naturally, the flow is reversed in the distal radial artery, and the ulnar artery has normal flow. So, we have high excess flow with Still syndrome that we need to fix. We schedule the patient for diagnostic angiography to rule out inflow stenosis, and then CT angio to rule out central arterial stenosis. Then we will treat the problem, either flow reduction or distal artery occlusion. This is the angiography. You can see the high takeoff, but we did not have much data. The radiologist should have done the angiography via the ulnar artery. Then we will be able to demonstrate the flow in that ulnar artery via the carpal arch to the radial artery with its reverse flow. On CTA, you can appreciate the calcified left subclavian artery but without significant stenosis that may cause Still syndrome. You saw the findings. What to do now? Flow reduction is the correct approach to start with. After the banding, the flow decreased from 15 ml per minute to 800 ml per minute. These are the steps we take for our unique banding technique. You can watch the banding video using the attached YouTube link. 2 months later, there is no improvement in Still syndrome with pain when the hemodialysis flow reaches 250 ml per minute. The next step is to prove the carpal arch patency. The ulnar artery has reached good flow that doesn't show any clinical finding of carpal arch occlusion. This is the angiography done via the distal radial artery with good connection between the two arteries. Now we have reached a turning point where we must to do something to improve the patient's suffering. The only step we have is occlusion of the distal radial artery, preventing the reverse flow in the artery. I don't like closure of the arteries, but the only other option is closure of the fistula, and I'm not going to take this option. Thus, we occluded the radial artery using microvascular plug system. Post-distal radial artery closure with MVP plug, 27 months post-op, there was no improvement in the patient ischemia. What now? We are frustrated and the patient refused to close the fistula. In July 2018, 34 months post-op, nothing changed, and he continued hemodialysis at 250 ml per minute. Half a year later, 40 months post-op, somehow the Still syndrome improved, and now the patient is doing dialysis at 300 ml per minute. 4 years post-op, the central cephalic vein is occluded and the major drainage is via the perforator. The flow is 800 ml per minute with good dialysis, and there is emptying of the puncture site with arm elevation. On routine clinical examination, 6 years post-op, there is no complaints of Still anymore. The cannulation sites are dilated. Unfortunately, a diagnosis of right renal and adrenal cell carcinoma was detected with pleural effusion and cancer-related hypercoagulability. Waiting for an nephrectomy, the patient developed a thrombus in the venous site. We initiated anticoagulation with enoxaparin. 6.4 years postoperative, right laparoscopic radical nephrectomy of the malignant tumor took place. 4 months post-radical nephrectomy, surgical thrombectomy of the venous side done to maintain the AV fistula patency. 2 months post-thrombectomy, recurrent massive thrombus occurred under Clexane 60 mg per day. Hypercoagulability, cancer-related, is probably the recurrence. 7 years post-operative, the fistula occluded despite daily anticoagulation with enoxaparin. Then, right perm cut inserted. We plan a new access with duplex planning for new fistula. We need hypercoagulability workup and repeat new CTA to rule out brachiocephalic and subclavian artery stenosis. What should we do now? Duplex mapping for new vascular access AV fistula at the left arm. Then plan upper arm basilic vein transposition fistula with anastomosis to the radial artery. So, 7 years post-op, what have we got till now? Brachial artery high takeoff at the axilla occluded, distal radial artery and recovery from Still syndrome 3 years ago. So, what have we done? Basilic vein transposition to the radial artery near the elbow level. Why radial artery? Because it is occluded at the wrist, and this way we avoid Still syndrome. 1 month post-basilic vein transposition, there are no symptoms of Still. Then we begin AV fistula cannulation. From the previous AV fistula, we have learned that there is a tendency to dilatation of the veins and aneurysm formation. 4 months post-basilic vein transposition, no complaint of Still syndrome. Hemodialysis quality is good and emptying of the puncture sites with arm elevation. However, the flow is low with a suspected inflow stenosis. 10 months post-basilic vein transposition, the patient developing ischemic symptoms. The hemodialysis quality is good and the flow is around 800 ml per minute. A duplex examination took place. You can appreciate the dilation of the cannulation sites despite the low flow. If you check the Doppler traces, you can notice the slow acceleration indicating inflow stenosis. What should we do now? Flow is perfect and bending is not relevant. CT angio is necessary due to suspected central inflow stenosis. On previous CTA in 2017, a calcified mild stenosis detected at the origin of the innominate artery from the aorta. On CTA, there is a severe stenosis at the origin of the subclavian vein from the aorta. You can follow the red arrow. This is a sagittal and frontal view of the stenosis with severe aggravation comparing the previous CT angio 6 years ago. Diabetes mellitus causes calcifications, but diabetes mellitus and end-stage renal disease accelerate the calcification. What should we do now? Brachiocephalic artery angioplasty with stent at the origin from the aorta. Endovascular intervention done at February 2023, 12 months post-basilic vein transposition. You can appreciate the stenosis and the management of the stenosis with the stent. On recurrent examination 1 month postoperative, there were no symptoms of ischemia, and the flow risen to 1 liter per minute after the PTA. On the forearm, there are absorbed remnants of the cannulation sites, and in the upper arm, nice and dilated cannulation sites. The hand and the fingers are well perfused. In this slide, you can compare between the pre-PTA and the post-PTA, showing the changes in the flow and in the Doppler traces. Thank you for watching this case presentation. You can visit my YouTube account, DishMHD, exploring more interesting vascular access and surgeries and videos.